please use the raise your hand function or send us a chat on Zoom, and we will get to everyone at the end of the press conference. Senator Kelly, Senator Hwang, take it away.
Thank you very much, Nicole. I'd like to thank everyone first for being with us this morning, to take time out of what I know to be busy schedules to hear what our vision for a better Connecticut is. And I'm also very thankful to have not only Senator Hwang, who has agreed to be here today and to also be ranking on insurance, but also Alan Sheketoff to bring some of the more personal aspects of what we're trying to accomplish here. Our plan, something that we've been putting forward for a number of years now, is I think a very good, common sense, pro-job, pro-family, pro-Connecticut plan that basically fulfills the promises made with regards to the Affordable Care Act. And that is that we would have affordable health care, there would be improved quality, and greater access. And our bill can do all of those things. First, with regards to reducing healthcare premiums, we work on the current, I'm going to say within the current healthcare system, utilizing reinsurance. People are going to be able to keep their doctor, keep their health plan, and their insurance carrier that they are familiar with. And what we're going to do is leverage money from Washington by using the 1332 waiver under the Affordable Care Act. And in this manner, we can reduce premium up to 30%. Second part is that healthcare is becoming unaffordable because there's cost drivers. That has nothing to do with the insurance industry, has everything to do with the high cost and expense of medical care. Our bill actually goes to the heart of the issue, which is addressing the year-over-year increase in medical costs. We've included benchmarking, something that Republican Governor Charlie Baker has utilized in the state of Massachusetts to save his state billions of dollars over the past several years by reducing what was a 10 to 12% year-over-year increase in medical costs down to less than about 3.5%. And in that manner, if we can do the same thing, we would be able to not only lower the cost of care, which is the actual driver, but if those savings are reinvested back into our reinsurance program, it would make the reinsurance self-sustainable. One thing we are also cognizant of when we are doing benchmarking is that we are not going to leave people behind. We need, and we will focus on making sure that benchmarking is patient-centered, and that individuals with either complex or chronic care, or individuals marginalized by the current healthcare system, that they're protected and become part of and have a voice in this benchmarking. We don't want to do this at somebody else's expense, and we want to make sure that those voices remain at our table. We're also going to look at the number one issue that is the highest cost driver, and that is prescription drug. Our bill now looks at importation of pharmaceuticals from Canada, but I'm also cognizant of, as chairman in 2018 of the Insurance Committee, we put forward a groundbreaking prescription drug reform that looked at transparency. And that information is now something that's coming back to the state from the good work we did back in 2018. And so this conversation with regards to prescription drugs is not going to end now, but is something that we are going to continue to look at and make sure that we drive down the costs for every family with regards to prescription drugs. Last session, we also put forward a bill that dealt with health equity. There are individuals in our community that might have the same economic status, the same insurance policy, utilizing the same medical providers, but yet have different health outcomes. We need to know why that happens and do something about it. Our bill last session, if passed, would have collected information over the past summer and fall so that we could propose new bills this year. Unfortunately, COVID came in and took that away from us, but we did have other opportunities with regards to special session in both July and September when this issue could have been brought forward. so that we could be addressing these issues today. We need to make sure that the promises and benefits of our healthcare system is a promise and a benefit that's delivered to everyone. And this is a way to look at that and make sure that that guarantee is made. We're also going to make sure that we have accountability and transparency with regards to the comptroller's office. I think this is very important when people are, taxpayers are making a sacrifice to provide the government with resources to do its job, that we have a government that is accountable back to the people. And therefore, we believe that this is an important component to make sure that transparency is present and always number one in our perspective of not only transparent, but also accountable. And then last, and I think this is as important as everything else, while healthcare is an issue that we hear day in, day out when we go and talk with folks in our neighborhoods, we also hear about the job situation in the Connecticut economy and how it's not performing for the middle class. Our state is dead last in job growth, dead last in personal income growth. And it's because policies that are promulgated out of Hartford by the majority Democrats have given us this fact. Well, it's because things like the public option, which would go into direct competition with our insurance industry, costing jobs, those types of decisions have an adverse impact on the middle class. However, our healthcare proposal not only will deliver on the promises of affordability, quality, and access, but we also remain the insurance capital of the world and keep the good paying middle class jobs in the insurance capital or in the insurance industry that actually enable families to pay a mortgage, educate their kids, and make our communities where we live the great place it is to live, work, and raise a family. That's our focus. That's why we came forward with these ideas. And I hope you agree. I think this is a better way, and it's why we're so excited about bringing forward these ideas. With that, I will turn it to our ranking member on insurance to take it from here. Thank you.
Thank you. Thank you, Senator Kelly, and thank you for your leadership on this issue as the former chair of insurance and longtime ranking member. I've learned a lot from you, and we do have a better way. And let me be clear, Republicans and Democrats all agree that health care is far too expensive and at this current rate unsustainable. I think we simply differ on how we have solutions. There are three current proposals out there in the Connecticut General Assembly. We have the public option led by Comptroller Limbo, which is a derivative of a partnership program in which they are performing a state-managed healthcare system. The second proposal out there is from Governor Lamont, which had a public hearing yesterday, which great feedback and insight were gathered, and in fact, mirrored a lot of the suggestions that Senator Kelly just articulated. There is a third proposal that will have a public hearing tomorrow at noon in the Insurance Committee, Senate Bill 1006, which was able to kind of articulate and put into language the suggestions that Senator Kelly made. We're very much looking forward to having a public dialogue and engagement to see how we can make all of these combinations work to the benefit of all Connecticut residents. I am extremely concerned, though, if I may, that Senate Bill 842 may be raised out of committee tomorrow morning at 9 a.m. without having the opportunity of our bill, a better way to be able to be complemented and to make the bill better. I think it's a question of transparency and process, and I hope that the chairs of the committee will not do so. I've asked repeatedly and have not been able to get an answer. So I think it's important for the public and a transparency note to pay attention to that. I think the second and more important point is we want to have a plan that works for people. It's not just about the idea of access to health care. You know, we had that experience with the Affordable Care Act when it was first promoted, that you will have the same doctors, the same plans, and the same hospitals. Well, the reality was that failed. And we're hopeful that before we proceed on any plan in the state of Connecticut, that the quality as well as the accessibility and the high standard of care is maintained. That all comes down to dollars and cents. And what our solution promulgated by Senator Kelly is the fact that we are taking this approach from proven experiences by other entities to use it to our advantage. The fact that we are looking at the various two other plans to impose an assessment or a tax on our healthcare insurance premium is another way of redirecting and impacting our middle class, because the bill is going to come due somewhere else. And ultimately, it's going to be in the middle class that bears the burden. So as much as we're talking about health insurance and the importance of it from a policy perspective and all the languages that you're going to read, I want to introduce Alan Sheketoff. Alan has been in the health insurance business as an individual that has counseled and worked with people in addressing the complexity and the emotional importance, as well as the physical importance of having health insurance. But since 1989, he has seen the whole gamut and have incredible stories of why Republicans and Democrats agree health insurance is essential. But you have also seen the overpromises and the premise that you can have it all when the reality comes that you pay too much and you get too little. So thank you, Mr. Senator Kelly, for allowing me to speak briefly. But I wanted to be able to introduce Alan Sheketoff for him to share stories from people on Main Street that are lives and impacted by health insurance and how we can create a better way to access that opportunity to them. So, Alan, please, thank you for joining us.
My pleasure. And actually, I have my son, Nicholas, and my son-in-law, Derek, who work here with me. Depending on some of the stories, I really didn't understand the format, but I will certainly tell you just from 31 years of being in this industry, the one common denominator that we've experienced is what we call change. Nothing stays the same from one year to the next, sometimes even from 1 month to the next. I am involved and sit on the board of all the carriers in Connecticut, which are far less now than they were when I first started 31 years ago. Especially there's two different types of markets. There's individual markets for people that are not part of an employer group. And then there obviously are the group plans, which are both small and large group, which are the many, many, many thousands of employers across the state of Connecticut. The markets and the carriers that are in both of those marketplaces are different. Currently, at least with the individual market, there's only two carriers left, those being Connecticut and Anthem Blue Cross. In the group marketplace, on the other hand, they've got those same two carriers, but in addition to those, they have Connecticut again, that's through CBIA, Harvard Pilgrim, Oxford United, and Cigna. That's pretty much the and Aetna, I'm sorry. But Aetna actually is a little different in that they do not have any fully insured plans in the small marketplace with 50 or less employees. That's changed over the last 3 years. They only offer what we call level funded plans, which is a whole different approach to how we do health insurance. And actually all the other carriers are now in that market as well. So when it comes down to how is this affecting the people in Connecticut, I think when we talk to people, we call ourselves the doctors of insurance. We really try to understand what their needs are, what their ailments are, what they do and don't like from whatever the plan is, if they have one, or if they're looking for one, what they're really looking for, where are the doctors and or hospitals or providers that they need to utilize, are they going to be in that particular network, and really what kind of a plan are we looking at? And then when we find out what it is that they really need to fit their needs, we then also have to look at one of the, I think, the most important pieces to them anyway, which would be the cost. And that's where it's become it's a difficult task, because unfortunately in the state of Connecticut, the way it works on both individual plans and also on group plans, the cost of the plan is totally based on age. That's it. has no bearing anymore with gender, has zero bearing on your health, whether you're perfectly healthy or close to dying. It doesn't matter when you go on to any of these plans. The way the ACA has been structured, it is all guaranteed acceptance. So you are covered, you are accepted as long as you go on at the right time, if it's an individual plan. And if you are a company that has 2 or more legitimate W-2 employees, or an owner and 1 W-2 employee, as long as the second employee is not the spouse of the owner, in which case that's not allowed, 2 or more people constitute a group, and then you can go on to a group plan. As far as costs, group plans today are slightly less than what the individual plans are, but they vary, again, depending on the plans, the metal level, which is the other complicated mess when Obamacare started. They have bronze, silver, gold, and platinum plans, which are just the level of coverage that you would get. Easy to understand, the bronze plans have the highest deductibles, the most out-of-pocket, least expensive. Silver and gold are probably the most popular options. The deductibles typically a little lower. They have more copays for certain services. And then the platinum plans are truly the best that you can buy, but the rates are literally through the roof.
Alan, if I may, can you just share a story of somebody who came to you that is looking for insurance, going through the struggle, a story? Perhaps there's a sensitivity for many people that they don't want to come forward and share their thoughts and stories. But in your many interactions with people, could you just share an example of the story that you had, in which the critical aspect of why health insurance is important, and you saw that in a client that you've interacted with? That's the real raw emotion of what we're dealing with here, is that what's the emotion of people that you have helped, and why it matters? Just share a personal story if you wouldn't mind. Okay.
Well, there are many, but obviously it becomes a choice to many of the clients that we meet with. I think as expensive as costs are nowadays, it's not worth not having insurance to potentially lose everything you have, especially in the era we've now lived for the last 14 months with COVID. People are getting hospitalized left and right far more frequently than they ever did before because of what was an unknown, and still a little unknown, but maybe a little better now. But certainly one hospitalization, if you're in overnight or 2 or 3 days, and God forbid end up in an ICU, you're looking at bills that could be $20,000, $30,000, $40,000, $50,000. So if you don't have insurance, you can go bankrupt. You could lose everything you've ever worked your entire life for. So to give you an example, if we have people coming to us now, and we've had people over the years, a lot of people who either, I like to use the expression, live under a rock or live in a cave, don't even realize there's a thing called open enrollment every single year. That's been reasonably consistent, other than year 1, 2014, starts November 1st. 14 started October 1st, and they gave everybody 6 months because it was a learning curve. But it's supposed to be basically a 45-day period where everybody has to make their changes, choose their plan, not have to prove any kind of loss of coverage or any type of documentation. Anybody can come on during open enrollment. Now, this year, because of COVID, they keep extending the open enrollment period, both federally and locally here in Connecticut. And people will come to us at various times. If they come outside of open enrollment and we ask them, when did you lose coverage? And they said, well, it's about a year ago. They're out of luck. I mean, basically, we can't help people because of the guidelines that are now in place, where if you don't come on during open enrollment, the only other time you can be allowed to come on is if you have what we call a qualifying event, typically the most common being loss of a group plan. So for whatever reason you chose not to come onto a plan within 60 days of loss of coverage, you're out of luck. Getting married could be a qualifying event. Being a child, turning 26, coming off your parents' plan. These are all the qualifying events that do allow you to come on to an individual plan. But part of the problem is a lot of these folks that left the company and do want to come onto a plan will call us, not realizing that a company plan, typically a good portion of the premium is subsidized by the employer. They're paying 50, 75, 80% of the cost. Mm-hmm. So what they used to pay while they were employed and have it taken out of their paychecks was significantly less than what COBRA would cost, which is the same plan, but now you're paying the full rate. And I think people get totally overwhelmed and floored when they see what the actual cost is. And then they will say, oh my God, it's $2,300. I can't afford that. What can we do? Now we can go out to the individual market. And
Alan, I must say, this is why people really like you. You speak so comfortably. And so thank you very much for your thoughts. And I want to also acknowledge Dr. William Pettit, Representative William Pettit, who has joined us in this meeting as well. But through you, Senator Kelly, if you want to be able to field questions from the reporters that are present through our staff. Thank you.
Sure. We can open up the floor for questions.
Members of the press, if you have any questions, again, please raise your hand, or you can send us a note in the chat function of Zoom, and we will get to you. All right. Okay, Mark Fish.
Hi, good morning, Senators. Thank you for having the press conference. I have a question in regards to importing prescription drugs from Canada. Are there any other states that do that?
Not aware that there's, well, first and foremost, we need federal approval in order to do this. So that's the first step in the process that would then enable states to do what we're proposing to do.
Okay, and do you have any concerns about getting federal approval for that?
Well, whenever you're dependent upon the federal government, there's always a concern. So, hopefully this happens and we can move forward. If it doesn't, as I mentioned at the outset, we do have the Prescription Drug Transparency Bill, which was adopted a few years ago, that I think is now just starting to take root. Prescription drug costs are the #1 driver in healthcare costs, and so we need to focus on this and make sure it works. But coupled with benchmarking, we believe that our plan can still achieve savings to move forward.
All right, thank you.
You're welcome.
If I may, Representative Pettit just texted a question, if I may ask for you, Dr. Pettit, or if you would like to ask it yourself.
Go ahead, Tony, take the lead.
No, I think the question, if I may, from what you share with me is, can you directly contrast the risks of your proposal versus the public option? Senator Kelly?
Certainly. First and foremost, what our plan does is it operates on the current platform of healthcare delivery. So our plan is fully compliant with the Affordable Care Act, and it will be regulated by the insurance department. So that's first and foremost. So you keep your doctor, you keep your health plan. We also rely on things like benchmarking, which currently are being undertaken successfully in Massachusetts and save billions of dollars. What the public option does is the public option is designed to be disruptive to the private insurance market, and it goes into direct competition with our insurance industry with a government-run program. Because it's a government-run program that pays healthcare costs through a fee, it does not comply with the Affordable Care Act. In fact, the public option as drafted would give the comptroller the ability to discriminate against people who seek entrance into the pool, and can create adverse selection, which are I'm going to say the foundation of the Affordable Care Act. And because it's a government-run program that's in direct competition with our flagship industry, it's also going to cost good-paying middle-class jobs. So what we both can do, we can get the same savings, up to 30% in our reinsurance plan, but where we're different is that we have all the protections of the Affordable Care Act, like pre-existing conditions, all the security of the insurance regulation, but we keep the good paying jobs in Connecticut. And I think that's a major and substantial difference between the two plans.
Another question that just popped up was following along the lines of what you said earlier. Are you saying with adverse selection under the public option, the protection afforded under the Affordable Care Act of individuals with pre-existing conditions could be adversely selected out of the public option plan?
Correct, Senator. I mean, that's the comptroller under the statute as drafted would have the ability to discriminate. Adverse selection then requires that that insured would end up in a different pool that's going to raise the insurance on those individuals. Their public option also has a provision to do Medicaid expansion, which is another way in which private health insurance, the cost increases for the middle class family. When you put more people on a government-run discounted health care reimbursement, that has to be offset, and it's normally offset with private insurance paying a higher premium. It's one of the cost drivers as to why insurance has increased over the last 8 years since the Affordable Care Act was adopted. And so this is not it doesn't deliver on the promise. And as we just witnessed with the COVID experience in nursing homes, and armed with the Mathematica report, which identified the low Medicaid reimbursement rate for the poor health outcomes that happened in nursing homes, I think the public option not only won't deliver with regards to a better program to reduce costs, because there is no benchmarking, there's no way to get its arms around the cost drivers, but it also is going to result in less access and I believe worse quality, because the Mathematica report demonstrates the poor health outcomes when you're dealing with a healthcare system solely funded by a government payment program.
Thank you.
Tony?
Alan?
If I could just chime in just to maybe simplify everything you just said, Senator Kelly, even though you said that very eloquently, I'm going to dumb it down a little bit. I think part of the problem in the public option, at least in the only draft I've seen of that bill, they have the opinion that Mr. Lembo could look at a group of people, and out of, let's just say, 20 individuals, 3 of them have major problems, cancer, heart, whatever. And because of that, he could say, we will take the group, but we're only going to take these 17. The other 3, they have issues. So totally against what the ACA is built on, which is not to be allowed to cherry pick the good risk and end up where the bad risks, we don't even want to take them. So what that's going to do is not only create a problem for that group, because now we have to go out and get those 3 people insured someplace, can't get them onto a group plan because they're no longer a group meeting the 75% eligibility requirements that all group plans have, because only 3 of 20 are going to want to go on. So we'd have to put them on individual plans. Group plans give you access to national networks. Individual plans do not. So all of a sudden you're giving people plans that are probably going to cost a little bit more, not much, they're similar now, but still a little higher, but clearly much more less as far as a network accessibility, whereas like a Blue Cross and an Aetna and an Oxford United that have networks in all 50 states, in the individual markets, you can only have access to Connecticut. And that's a big deal, especially to the 3 people that have got ongoing medical issues. They're now being put in a very precarious situation. Number one, not getting the same quality of coverage and more than likely at a higher rate. And thirdly, different than the plan that the rest of their employees share at that same company. To me,
that's a perfect end off. Nicole, go ahead.
I was just going to say we are all set with questions. So thank you everyone for joining us today. Again, the Connecticut Senate Republican plan is on our website, ccsenaterepublicans.com. Kevin, Tony.
Thank you very much.
Everyone.